I'm going to switch now to an area that we've talked about, these technical licenses and professional skills that we need. We do need them. But one of the things that I want to put in perspective for those of us who have a little bit more of a public health perspective, I think we know, but I wanted to affirm this, that only, the next slide will show you that actually where it starts with is looking at what kind of health outcomes do we really want. And part of it is length of life, but the other one is quality life at the top, very top left column, 50% for each. And if we look at the far left, the green box is health outcomes. But what comprises all of this are health factors, and these are the ones that are in the lighter blue. It speaks to health behaviors, the clinical care, I'm going to come back to that, social and economic factors, and physical environment. And at the bottom left, the policies and programs that begin to enable this. So all the areas of geriatricians, nurses, social workers, recreational therapists, I haven't brought up the home care world yet, but all that more or less fits under that 20% of clinical care. That's all it is. And so, and because we're a professional group, we of course would focus on that. But I think this is a time to think back to the lens of what public health is and what helps people maintain their quality of life and their length of life. And so some of the health behaviors that you see on the far right in smaller boxes are things that we know about relative to smoking, to being mobile, our use of alcohol, and down further is relative to the community that you're in, as well as your economic viability, which is an area that we oftentimes don't talk about as healthcare providers because we think that's out of our scope. But if our goal is about better health outcomes, this is absolutely key. And there has been some research recently on the other end of the spectrum of children, that what makes a difference in poor mothers and the well-being of their children in terms of not only their physical health, but their cognitive and learning brain, that the best thing that they can get is an economic investment during that early period in order to do this. So we're bringing the world of health and health care closer together if we're willing to think about that construct. The next thing I wanted to raise is this whole area of when Louise brought up the fact of consumers. And this is something that has been very dear to me, that relative to how important that is with the public. Many of you may not know I'm a nurse by training and my background, but when I was in training, things that I saw in the hospital 45 years ago were areas that I just did not like. I thought I was so excited to go into nursing school. I'd been a candy striper for like 3 years before I started. But then I went into the training of the system, and I suddenly realized the hospital is definitely near where I personally didn't want to be because of the amount of disrespect that I saw at all levels at that time, relative to, like nurses actually were asked to stand up the minute a physician walked into the room. And I had a physician who, in the middle of my very painful dressing change of a woman who was dying of pancreatic cancer, who wanted me to go get him a pair of gloves from a closet which was within eyeshot. I just couldn't believe it. I was in the middle of this, and I felt such disrespect at that time, but for the patient. And so I ended up going straight into community health, community services, where I could be frankly on other people's territory. And it was humbling. I learned some real painful lessons that I didn't know everything. But I realized then early on that the ability to understand life, health, and thinking from a person's perspective rather than me, Tarzan, you, Jane, relative to our expertise, it really changes the equation if we're really about the goals of the person. So this particular paper that came out of AARP has taken a very close look at caregivers. This came back, this actually was published in October 2012, and the title, of course, is really catchy. But bottom line is it means that family members are left to themselves. They get discharged, their loved one gets discharged from the hospital, they get given a sheet of paper. This is 2012, mind you, and off you go, you know, and I might be a Malcolm Baldrige certified hospital, but once you're out those glass doors and in that wheelchair and you try to get into your car, you're on your own. In the old days in the hospitals, we used to be able to send home medicines with people so they'd have a transition. But no, nowadays, more than not, you have to make sure you have to go to the pharmacy to get your medicine, let alone knowing who's going to kind of reconcile them. But you have to do that before you go home. You have to gather gauze, bandages, and things like that. You know, you're on your own. And so one of the things that ARP was able to find through this national thousands of people study of people who went home, the caregivers were not just under stress, as we hear about so colloquially, and the fact that their economic viability is compromised because they're at home, but almost 46% of people are doing medical surgical things at home on behalf of their loved ones, and have gotten very modest instructions on how to do this. And the medications, and especially with older people often being prescribed as many as we know, sometimes surprisingly like 20, 25 medicines, the family members are on their own to do this, and they are very nervous about it. They're highly anxious about it because they feel they're going to screw up on something. So one of the things that it strikes me, and I think we all know this, that we may do a great job in our licensed programs, but when we basically put them on the ice float, they're really on their own, and this was found to be hugely stressful. So that's the state of affairs today. This next slide is a follow-up study on another dimension of really just looking at who is the caregiver workforce right now, and it's the people who are, we're at our heyday, believe it or not, in terms of the number of caregivers, family caregivers, friend caregivers who are available to help an older person. So 2016 is what I'm pointing out, and we're probably about 6.5 to 1 older person who needs care. Well, in a mere 14 years, it drops down to 4. By the time we hit 2050, there's 2.5. So I'm giving you some of these little tidbits to kind of think about as to, you know, why the urgency is there. But the number of family caregivers is significantly dropping. This next slide points right now to the economic value that we contribute as family caregivers. So it turns out 1 out of 4 of us who are over 25 years of age are doing something relative to family caregiving. It may be as much as 40 or 60 hours, it might be an hour, but bottom line is 72% say that they really would appreciate a lot more flexibility relative to help at home. And the economic value of the family caregiving, because this has policy implications from a governmental standpoint as well as a industry standpoint. Laid across there is the economic value currently, and I just want to show you the first dark blue bar is the value that Walmart brings. The second one is what family caregiving. It's just $4 billion less. The total Medicaid spend in the country is $449 billion. And then you see out-of-pocket costs and long-term care costs. So right now, there is so much economic value given to the country that's quiet. But it also does affect those people who are basically giving up their work, and they have estimated it's about $300,000 when you think about their Social Security being affected in the future and all. So what do we do about these reports that come out? And one of the things that AARP has done is this very issue to start with, and that is, this is an example of some policy change. And I know hospitals aren't crazy about this, but it is being accepted because it's just probably a bit of the modification that you know about the transitions of care work that is going on, that Mary Naylor has spoken to this audience about, and that's one component. So it's building a little bit more on that transitions of care plan. So it's beyond having a checklist of what to do and to make an appointment, to make sure that you have an appointment within 2 weeks and a phone call. That's good, but what's necessary is that medical nursing stuff that people know they're going to have to do, the medications they're going to have to do. So there's something that's necessary to have. And your state here in New York is going to be instituting that. The legislature did pass that. And so in the end of April is when this takes effect. This is taking effect in California as of the beginning of this year, that the hospital systems are tooling up to just make sure that people have better instructions as they leave the hospital. And so on the one hand, it seems like a lot more work, but the reality is incentives now are better aligned, because if somebody comes back prematurely, the hospital would pay. So in some ways, this gives them a systematic way to do this and have an ROI on that activity. So all this is happening, these little aspects of knowledge that we have, and you wonder how this gets tied together. Well, I think this is just a fantastic time to recognize this. There is game-changing going on. And what is really quite interesting is the marketplace, not the healthcare marketplace. We're going through this with the ACOs and bundled payments and things of that nature, but the outside marketplace is paying attention. And there are a lot more non-health people who are beginning to do this. So let me just give you a few examples in the course of it. So many of you probably know that there are increasingly senior coordinators in housing projects. HUD, which is the government agency that runs many of these senior housing projects, used to never allow, quote, services in their program. And so that if somebody got frail, they had to leave that building and go somewhere else. So now there are service coordinators to help people stay in place and mitigate their frailty. And so the CMS has actually invested in this Vermont project to show to replicate the work that they did, to show that having a housing coordinator that is informed about some of the evidence-based practices on falls prevention, activity, and nutrition actually mitigated a lot of readmissions in the course of it. So it was highly successful in the course of a one-year study they did, and they're doing it with all of Vermont right now. But it doesn't engage professional people. It may use them as consultants at the very beginning, but they basically do it with non-healthcare people, and they also get the residents themselves to be engaged in this. And they are able to do this and not necessarily, rely on the licensed professional to do this kind of care. This next slide is just interesting because it talks about workforce, the shortage of physicians that we have. This is something that showed up back in 2014 at MIT. There is a mathematician by the name of Max Little, and he actually he was going over some voice recordings, and it was a more mathematical formula. And in the course of doing that, found out that he can see the difference or hear the difference after a 10-minute conversation on the phone to pick up and record some early changes that occur for people with very early Parkinson's disease. And so this is where actually this kind of sidesteps a neurologist. This is somebody who's able to do this in a very different way. So this is just one example that things are kind of coming off sides for us that are opportunities to think about care and service in a different way. So this neurologists are really a shortage specialty as in many others, but this is something that we can begin to do differently. And here it's a mathematician who's actually contributed to the conversation. And his accuracy rate was over 99% of the time when it was verified. So this slide here speaks to the non-health provider doing many of the kinds of things that we are tending to do. The Y has actually moved into the whole area of obesity counseling. And the ability to do this is done because they are using the tools from some evidence-based material, and they're able to implement these programs and get outcome results of people, bringing down their weight and their lab results for 25% of the cost that we would have done it as professionals. And so the ability to start thinking about so much of this evidence-based stuff that we have around, and we talk about having our professionals adopt them. Of course, we really should be doing these standards, but we can secularize this. We can democratize this knowledge. And then the whole issue of cost, of having $3 extra on, out of $4 to have $3 extra to use it for something else in terms of societal spend, that is fantastic. OASIS is a program that is based in the Midwest and really builds on intergenerational support. And so that's something that has been growing. And then the last example at the bottom are the Black Churches Network, along with the Methodist Health System. They have signed up about 500 churches in Memphis to be a part of this network with the hospital system on readmission, because they're really very attuned to the culture and the knowledge of communities and the influence of the pastors in the churches, and they too have brought down their readmission. This was before the readmission penalty even really came into play, because they just saw people cycling through the hospitals. So again, we've got to get outside of our usual walls that we are there, they tend to look at. And the framing lens that we have to do, and we're so into the diagnosis or figuring out what we're going to do to people. There's Susan Edgman Leviton from Mass General Hospital, who is actually a physician assistant by training, really has been attributed this phrase of not saying, just what's the matter with you, what matters to you, and asking people themselves as to what is important. I think that Pat Baum, who is here and has really carried the most work in the state of New York, has been a part of that process of really getting people's wishes and knowledge written, as well as formalizing it so that it's going to be honored legally. But it's really about what matters to people, and this is really quite different. I think many family physicians and social workers and geriatricians have always asked about this. The palliative care physicians and providers do this tremendously. But we have such a focus on making sure that we know what's wrong. And one of our geriatricians at Mount Sinai, who's a palliative care physician, Sean Morrison, gave an anecdote. He said he met with the daughter of one of his patients. His patient was over 100, the daughter was 75. She came in to talk to him about her mother, but she said, I've had some problems, and I went to see my own internal medicine doctor, and I told him what was wrong. And I got 9 referrals to 9 different specialists for that. And she said, you know, I don't care about some of this other stuff. I mean, there are 2 things that bothered me, and that's what I wanted. But what happened was she got this full top-to-bottom assessment and then got referrals off to other places. So you can see why, one, the care match and what's important to people doesn't always match, even though technically that assessment was there. But 9 referrals to 9 physicians, you can imagine the costs that were incurred there. So the next one is really speaking to the role of beginning to think about technology. So I start with actually with children's technology, that they're using a teddy bear right now to help children learn how to manage their diabetes type 1. And the ability to have this interactive and have the electronics behind it as well is something that is there. So again, this is geared for children, but you can begin to see a shift of people who are in this innovation technology space who are beginning to think about how to do this so that people have greater capacity. The next one is relative to 3 examples. One is on the far left about socialization, making sure that, say, grandchildren can connect to their grandchildren, grandparents can connect to the grandchildren from remote and have this ability to have books read to them and whatnot. And obviously the connection is that sense of belonging to something and having a purpose. So using our tools now, whether it's Skype or whether it's FaceTime. The far upper right is that there are a gazillion companies now developing medication management tools. And so again, people are jumping into this. It's like, you know, your industry is getting hot if you have a lot of entrepreneurs who are coming into it. And the bottom one on the right is something that we actually saw in Japan. ARP was looking at how the Japanese were thinking about technology. And this is Paro, P-A-R-O. It's their little baby seal, and used for people with Alzheimer's disease and works very, very well. And so I know of another entrepreneur in the Bay Area who's created a physical doll. It was life size, weighs the same, does actually feed. Amazing degree of calmness, and again, it doesn't look, you know, cheesy at all, but has really been a tremendous tool for helping some of the people with dementia calm down. Rounding the bend here, we really do need a whole new system. And I think the fact that there is a lot of opportunity right now, diabetes is probably one of the areas of focus, but this affects a lot of older people. But there is more of a shift, not just in the technology tools, but understanding and engaging people themselves. It's interesting, I was asked to speak at UC Berkeley's business innovation group for students, and they had bake-offs. You know, they had teams where they were developing tools, and they had an expert panel of people from Silicon Valley evaluating this. So one thing that was quite interesting, the few people who stood out were the young teams, and they were interdisciplinary, who chose to ask older people themselves, how was this working for them? Other teams just designed these things and, you know, basically thought that this would help an older person do much better. But one of the big messages was, you know, check to see where people are thinking about this, what their capacity is. There's a whole new area of study that is about co-design and co-development. And the people who choose to do that, they will probably align far better. And I put the 2 bottom bullets are that we saw back at the public health side, that social environment is absolutely crucial as part of maintaining people's well-being. And this idea of bowling together, meaning you've got to have some set of connectivity. And some of you have even seen that the Wii game has been used for this virtual bowling, and it just allows people to both physically move but be part of a group. I'm going to switch for a few slides now to really talk about what's happening internationally. What is it that we can learn? And this slide is of one of our colleagues that I've met through the Institute for Healthcare Improvement, the Sir Lord Nigel Christ. And he was the head of the National Health Service under Tony Blair. And Tony Blair said, sent Nigel out to go out to the Commonwealth countries to see what, in fact, they could help share from the UK to help their Commonwealth colleagues. And so he learned a lot. He came back very humbled. In fact, he wrote a book that was called Turning the World Upside Down, because here we were ready to do some of this developed world kind of transfer, and he learned something quite different, and I'll give you an example. But this is where the UK is further ahead than I think the United States. They got together both houses of Parliament in order to take a look at this whole healthcare workforce, and this was done probably about 5 years ago. A publication that was called All the Talents, and it involved a very cross-sector approach to this. They were looking, these were the different countries that they had a chance to do, and listed at the bottom was what came together, thinking about how do we think about healthcare workforce. And I'm going to give you an example of two things that they've done through this UK effort to have some results. One is on the left-hand side. This whole prescribing by nurses apparently is, in the whole area of primary care, has actually produced better outcomes as well as higher satisfaction. And this now, the FTC on our side here, and on this side of the pond, has really come to the fact that this is one other possibility for thinking about different roles. But they actually have done quite well. What's more radical for us is what's on the right-hand side in Malawi. And in Malawi, at the time they did this initial study, when they were looking back at this, there were only 7 orthopedic surgeons throughout the entire country with all the kind of orthopedic issues that they had. And so what they did was they chose deliberately to train what a title of group of people called clinical officers in orthopedic care. And so they basically thought about the things that the orthopedic surgeons themselves would do, and then what these officers would do. And after 10 years, at the very bottom right of this program, these orthopedic officers were seeing 153,000 patients and performing 33,000 bone manipulations and 3,700 minor orthopedic operations. That would never happen here. We know that it is not possible, but it's something I use just to jog us that when you have real need and you are trying to meet the needs of a population, somehow you get through this. And so from 7, they had, I think, 110 people trained in this particular program. So one of the things that also all the talents did was to really begin to separate what kind of leaders and skills do we need. We need people who are technical experts, who have information and skills. And then we have people who are in their, what they call formative level of professional contribution. And by that they mean people who tend to be the teachers and pass on some key values. And then finally, the ability to have enough people in their system trained or allowed to be transformative, because they help push the envelope, as we would tritely say, to really think through what the system is going to be needing. So, and we're at that point for ourselves. You know, our focus has been so individual, and now we're moving to the phrase of population health, which is really public health in today's age. And this is something the Gates Foundation is doing quite aggressively. I was really lucky to be there last week. And they are really taking on this whole aspect of aggressive public health. They really are pushing this. And what's interesting is they're talking about eradicating poverty as part of it. So they have committed to the aspect of economic stability as part of what public health is about. So nowadays we are moving far more from the institutional focus to making sure that it's across sites of care as well as in people's home, and our willingness and ability to begin using people who are not as skilled and licensed as we currently have. And using technology that we don't currently employ in a way that makes it easy both for data as well as for outcome. So back to the consumer side that Louise mentioned, I am really very excited about some of the efforts and the work that are coming on a federal level, which is not cited here. It's called PCORI, that we all know had come along with the ACA. But one of the things that has been absolutely key about their structure is that they have had a consumer panel as a part of this from the get-go. So whenever this big study that they're doing right now on falls prevention with the data that's happening across multiple sites, it's the consumers who have been shaping this. So one of the big, I think, big thoughts that we have here is rather than rely on the beneficence of what we've historically done, and that is me, Tarzan, you, Jane, is the fact that, you know, we're going to swing together in making the design happen. Just as I told these young MBA students and technology students, you've got to understand and really engage the customer at the front end, not just do something that pilots it after you've put in a design. And so PatientLikeMe and this person who, if you don't follow him on Twitter, this is Dave DeBronkart at Patient Dave, is somebody who's now brought in quite consistently on South by Southwest, all these kind of engaging areas of innovation to really assure that voice of the person who's affected. And as more professional people get affected, the whole Patients Like Me was started because of a software developer whose brother had gotten acutely sick with an unusual disease. And so now this whole organization has grown tremendously. So what does this mean for our future workforce? So is it time for a big shift, you know? And I think the little edgy things that are happening, there are important in-system changes, as I hope to talk to the folks tomorrow relative to the co-management that we have geriatrics and whatever the specialty might be. That's absolutely vital. But in addition to what we do professionally, what else can we do? And this innovation is, as I say, happening outside of a lot of our venues. I'm on a couple of startup companies that Louise mentioned. You know, one is using a technical tool. The other one is looking at how to help direct care workers at the point of care in the home use a whole evidence-based set of information that have been developed into algorithms as to the most common issues that happen when the person is home. And then separately, when they're stuck, that there's a live help person to do it. So at that one transaction, all things can happen. Again, not done by anybody from our geriatrics field, but people who are coming in from Google and others that are looking at this. So I think we need to just take a deep breath and realize that we know about the insufficient number of prepared personnel. What else can we do? Using the concept of all the talents, and that includes the family caregivers, in addition to our traditional thinking that we're expanding beyond our professional licensed individuals. And technology interface is definitely on the move here. So for me, I think that our core training, when I was educated and trained as a nurse, I was doing things right so I wouldn't make a mistake. But there's an implicit statement there when you're doing it that way. You basically don't want to make an error, okay? So we're looking at safety, which is real important. But when you get trained so fully, or the fact that you only do evidence-based practice, what if there's some variation here? And so if we're doing that only and thinking that that's the end point, I think we have lost the value of what evidence-based practice is. There is quality improvement. There are positive outliers that we have to look at. So the evidence is important for safety, but let not this be the only ends. And I'm saying that this is an opportunity for doing the right thing. And for me, I'll posit that doing the right thing is thinking about our population's well-being, helping people live their best lives, live it safely, and when they get off the rails, is there a way that we can get them back on the rails safely and quickly so that there's a sense of being able to live your life again, not feel that this is forever there because I don't get to see you until 3 weeks after you've been discharged. And so I think this is where I call upon us to really allow some time for the macro way to think about it and think about equity, access, value. And value includes cost. Doing the highest quality for high cost is not something that's going to be a sustainable intervention. And so as I wind up here, I'd say, with the clarity of purpose and collective effort for the greater good, we can do it with all hands on deck. So each one of us are probably one of those ants, and we couldn't do that heavy lift, but when we pull it together. And finally, I just forever keep thinking about this, about Margaret Mead, and I think we all know this, but I just find that this is one of my true norths of thinking about the work that we do, that we can do it with a small group of us, and the fact that here you've assembled over 100 of you together. This is not exactly a small group, but the fact that you're beginning to have a shared sense of urgency and purpose is real important.